Your host, Jean Armand. The Health Flow podcast is designed to share healthcare information and experiences that will educate and empower you to make better health decisions. This week, my podcast is about uterine cancer, cervical, and ovarian cancer. To begin with, cancer is a disease in which cells in our body grows out of control. The cancer is named for the part of the body where it starts. So if it starts in the breast, it becomes breast cancer, and so on. Today, I'm happy to introduce my guest, Miss Kenya Ragland. Kenya is a family nurse practitioner. She's a graduate from Emory University in Atlanta, Georgia. She's been a nurse practitioner for over 11 years, and she's currently employed at an oncology infusion center at a hospital in the greater Atlanta area. Welcome, Kenya Ragland.
Thanks for having me.
You're welcome. Fun fact about me and Kenya, we're really good friends. She's the one that came with me to London and was my supporter. So this is my good friend. All right, so Kenya, let's talk about your role at the infusion center.
Okay, so
Well, I'm sorry. Let me interrupt you. Tell us about yourself first, please.
Well, like you said, I've been a nurse practitioner for 11 years. Most of my background has been ER, but recently, in the last about 4 years, I have been working with GYN oncology. That GYN meaning that uterine, cervical, fallopian, ovarian, all those are considered GYN oncology patients. At a hospital that deals with cancer, and it's something new where they have to have providers in these facilities now for different reasons. But it's something new and I enjoy it. So it's a big difference from what I'm used to, the ER.
Okay. So what is your role at the infusion center? What do you do?
So it has expanded over the last couple of years. Initially, we were there for emergencies. I didn't realize how many people have reactions or sensitivities to these chemos and the preservatives. So we was there for emergency situations. We managed their labs to see if it's okay for them to get chemo. If their white counts drop too low, we give them medicines to make sure they can stay on their chemo regimen on course. We manage any of the symptoms that they have while they're there. Of course, nausea, pain, any of those type of things while they're in the infusion center. So
And
we
when,
work closely with their doctors.
and so when you say we manage them, really you're the provider that's there. You order things to help them through these reactions, and there's nurses there that carry out your orders.
Yes,
Okay.
exactly.
Perfect, perfect. So, do you have any personal experience with cervical, ovarian, or uterine cancer?
So not me personally, but I recently, my mother, it was just surprisingly that I was working in this field that I was able to get her the care she needed, but she was diagnosed with uterine cancer in October 2018, and she just finished treatment in March. So it was scary to know. I just knew just enough to be horrified, but I was able to get her the care quickly and that she needed. And I'm glad that she was felt comfortable coming to me, knowing that I work in this field now, to ask questions. So we knew to get right on top of, getting her looked at, getting her seen by a physician.
All right. And the key thing was there was early detection and early treatment, right?
Yeah, so that's the unfortunate thing about most of the GYN oncology cancers. There's no screening. You have to be diligent about things that seems abnormal to you. The only screening we have mostly are for cervical, of course, is pap smears. If you go in, each year and getting your scheduled pap smears, and that's one is easily treated if it's caught early. But for uterine, ovarian, they don't usually present any type of way. A lot of people don't even have a lot of pain. Something as simple as bloating or bleeding And I know you'll be surprised how many people, ignore like, oh, I have some abnormal bleeding or spotting in between periods or postmenopausal bleeding, which some people ignore that for months or a year. So, I mean, going to get something checked out that is abnormal for you as soon as possible is the biggest thing, because a lot of these cancers are actually treatable if they're caught early.
If caught early. And
Yes.
just to emphasize what you said, the Pap test does not screen for any uterine cancer. The only cancer that the Pap test screens for is cervical cancer.
Right.
And that is why if you develop any abnormal symptoms, meaning bleeding after you've gone through menopause, bleeding in between periods, bloating, unusual pain, pain with sex, these are all things that you need to be diligent and get them checked out. That's the only way to just be in tune with what's normal for you, not for someone else, but's normal to you.
Right.
Okay, so what types of treatments are done at the infusion center?
So we provide. This is where because everything is outpatient now, or people used to be put in the hospitals to receive chemotherapy and then go home. They are now coming to an infusion center to receive this treatment so they can go home the same day. So they're not admitted to the hospital anymore for these treatments. In the infusion center, we also see other types of cancer, but I'm responsible for the GYN oncology patients. We see bone marrow transplant. We even do some antibiotics, some other things. But a lot of those patients, some of them even have to come every day of the week. So we're open 7 days a week, 365 days a year, so people can receive their treatment. So whether that's Saturday, Sunday, whatever day, 7 to 7, we're there to make sure they can get their treatment. So we are, infusing chemotherapy in the infusion center.
Okay. And how do you get your patients?
So they either come through emergency room and it depends on what their diagnosis is. They are linked up with the specialty that goes with their diagnosis. And then the physicians, because we have a lot of oncologists that are associated with the hospital that sends them to the infusion center. A lot of the doctors used to do a lot of infusions in their office because of reactions, some bad outcome, cost, all those things is now being sent to a central infusion center that's attached to hospitals. So all hospitals have infusion centers now.
Okay. I'm just trying to kind of make it clear so that our audience can envision what we're talking about when we say an infusion center. So an infusion center is like a location or a department within a hospital that's manned by nurses. Yours particularly, you have registered nurses, and then you have you who more or less carry out the orders for the chemotherapy that the oncologist has recommended for these patients.
The oncologists have recommended and have written the orders. We making sure that they always usually come in a day or two before to get lab work drawn, or they go somewhere else outpatient. And we're monitoring those labs to make sure that, because they have to be in certain parameters to get chemotherapy. So we are checking for all of that. And if it's not, if their white count is too low, things like that, we recheck that there. And, I communicate a lot with the physicians in their office because they can't be there. They're seeing patients in the office or doing surgeries. But it's a huge open area, if you can imagine. Most infusion centers have like panoramic, windows with a bunch of recliners. Some have televisions. It's a little more relaxed. It's not quite like a hospital, or I don't know what to compare it to, but it's an open area with a bunch of different recliners. We try to make it as, comfortable or as home-like as possible. When you have TVs, people are eating food and drinking coffee, and, they just so happen to have an IV attached to them.
Right, receiving their treatments.
And
chemotherapy is really an infusion of IV medicine through the IV. It's not That's totally different from radiation. I just want to make sure everyone understands that chemotherapy is like the cocktail that's prescribed for your specific cancer, right?
Right. I mean, my mom was, she was wondering, she never did ask me because she knows I do this, you know, every day I go to work. And she was like, I was wondering how they was going to get this chemotherapy inside of me. And I was like, such a simple question, but you just assume everybody
Yes.
knows.
And they really
Yes.
That's why I said
so yes, you're right. Most people, because she did not quite understand, like, well, how do you get it on the inside? So yes, it's the IV, just like if you get an IV fluids or, you know, anybody, you ever been sick and just got simple fluids, it runs in just like that.
right. And how
And
do they know? This sounds silly too, but it may sound silly to us, but I know it doesn't to the everyday person. One of the things that I find that people are very cautious or against chemotherapy is because of the side effects that may
mm-hmm.
occur. Can you kind of like just go into that and, you know, we'll talk about some things, you know, like how those side effects aren't long lasting. And you can even relate to your mom about things that happened to her at the start and now where she is now that she's completely finished with it.
So I can even say for myself, I mean, and television really, you know, screws your whole view of what getting treatment for cancer will be. I thought people were going to be sick and, you know, pale and just, I'm in bed all the time. It has changed so much over the years. The research has shown they have medications that they give you before to be proactive instead of reactive to nausea that you know the medicine is going to cause. A lot of the patients, especially GYN and oncology patients, have little to no nausea, hardly ever any, you know, vomiting. You have those 1% people that, you know, you always worry about those people that get car sick or was very sick when they were pregnant. You know, some, you know, put people at higher risk to have nausea while they get chemotherapy. But most people, including my mother, who's 72 years old, had little to no side effects from the chemotherapy.
Wow.
Now, some other physical things like, you know, you always worry, you know, some of these things cause neuropathy or some of these things cause pains or some of these things cause your nails to get brittle. I mean, those are some of the things that are pretty common in certain chemotherapies. We already aware of them. We know to monitor for them. I'm looking for that every time they come into the infusion center. But the big things that I think people in their head, they're so worried, like I'm about to be sick. You know, I'm about to be pale. I'm about to lose all this weight. Most of my women hardly ever, if anything, they almost sometimes gain weight.
Right.
Great appetite. But we have medicines now that are, you know, after doing research, we know to give with this medicine that lasts, because we know day 2 and 3 is when you're going to feel some, you know, some of these side effects that are able to last past this point where most people are still able to function and go to work and, you know, hang out with their friends and all these type of things. So it's a different picture than what I think most people have.
Okay.
I was glad my mom had the opportunity to have me there to explain, like, you know, I know this is probably what you're thinking, but this is what I've been seeing the last 3 or 4 years.
Right. What about hair loss?
So yeah, so most of the chemotherapies cause hair loss. Some women it doesn't bother. I think, you know, a lot of the women I didn't quite understand myself, but it's like I guess the one thing they can control. But most of the chemotherapies causes you to lose your hair on day like 14 to 15.
Hmm.
They have I've seen some women wear cool caps and things like that to kind of minimize the loss.
Hmm.
I mean, I personally don't necessarily think it works, but
Right.
yeah. But all the chemotherapies don't cause hair loss, but the treatments that we use for ovarian GYN oncology patients, it usually causes hair loss,
And the hair grows back.
and the hair grows back
Okay.
once you finish treatment. Matter of fact, it starts growing back between your treatments. It starts to get a little fuzzy, and then you get another treatment. But yeah, once you stop treatment, when you know, usually about a month, once the chemotherapy is out of your system, it starts to grow back. Yeah, that's what I always tell them when people, if anyone has, and I've had women that come in, they have hair down, past low back to their behinds, and it was like it grows back. It grows back.
It does
And some
grow
people
back.
have refused to get treatment because they didn't want to lose their hair.
Yeah, that
Yeah,
is, oh my goodness.
it's a
I know. It's
yeah.
just fear, the fear of the unknown. And yes, we know that treatment of cancer was, research is getting better, it's getting more detailed. They're able to target specific cells. And then, so the other cells, well, the whole thing with chemotherapy is that you're going to kill good cells and bad
Yes.
cells.
Yes.
And then the rapid dividing, I do believe that's really the explanation for the hair loss is that with your hair, those are rapidly either dividing or the way
That's
they
exactly
grow. And so
right.
that's why you will lose those, but like you said, you
Right.
will get it, you'll get it back. One of the things that I'm thinking, when you said with your mom, and I just want to encourage any person out there with family, when and if, I hope not, your significant other has to go through something like that, is to always talk about the importance of having family support during this time.
Yes. Yes, you do. And just being aware and being okay with asking questions and not just like you bother anybody because and my mom said all the time, she's like, well, I'm glad you was at least able because when I wasn't working, I was with her, I was her daughter. I wasn't being nurse practitioner in Kenya, I was being her daughter. But you do see some people that are there by themselves going through this process, and it's a lot. It's a lot for the family members, it's a lot for the patient, it's a lot. And it is nice to have some support. I think everybody needs some support, but it's a full-time job, and to expect someone to jump in and take over because sometimes treatments can go 6 months, and it's going to appointments, going to get labs, going to get the chemotherapies, going back to a doctor again.
Right,
It so it is nice to have some family member or any type of support, friends,
right.
anything.
Yeah, I've seen some wonderful families that like have notebooks. They're writing down schedules. They're keeping up with what's going on. The patient themselves don't even sometimes can't even understand. They're not hearing it. They're the ones that's not feeling well and they're dealing directly with the diagnosis. You just need that outside family member who's going to remember, record things for them, take them to the appointments, just take over, like you said, how you were just able to be there for your mom. Just, I encourage people to just make sure that they help their families when they're going through this.
Yes.
All righty. So, what kind of suggestions do you have for women like working in this area? What do you see? What are some of the barriers of care um, for people, for women being diagnosed, getting treatment, all of that? What are some of the barriers of care you can think of? Barriers to
The
care.
first, and I know I see a highly concentrated because there's very few GYN oncologists, in Atlanta that specialize in most areas, but especially women of color, the fear of not knowing or just the diagnosis. As a lot of people know something is wrong and they don't want to know. So they feel like if I don't go to the doctor's office or if I don't get this checked out, it's not really there.
Right.
Um, I know a lot of the women waited months, and I always ask. I just sit down and talk to them. It's like, what made you finally go to the doctor's office, or what brought you in? And it's just like, it's usually a family member start noticing symptoms and things that kind of force them to go, but they've had symptoms months before then.
Right.
Um, that's and it's pretty sad because a lot of these things, like I said, if it was caught early enough, the treatment sometimes is just simple surgery removing, but you wait too long, you have to get chemotherapy, and
Right.
a lot of these diseases are considered chronic because by the time you find it, it's not a cure for it.
Right.
um
Go ahead.
Cost, of course.
Hmm.
We see a lot of especially the ones that come to us don't have insurance, so a lot of people is like, I'm feeling bad. I would normally go to the doctor's office for this bloating, or I don't feel quite right, but I don't have insurance, or I can't
Right.
afford to pay this right now. I got, I can't get off of work. It's just so many things. So cost has usually been a big thing that
Right.
made them delay it for so long. But I always tell, it's so many resources out here now. It's so many, it's almost cheaper to not have insurance at this time. I don't want to say that you should have insurance, but it's a lot of doctor's office, have a flat rate was like $125. You can come and get the pap smear and do these things and get checked out.
Mm-hmm.
And it's not such a big thing. I think people think it's more expensive than it is to do something simple, at least for the screening parts.
Right. Right. And also just for women to know, I mean, I had a like a just a flashback of a woman that I was doing a clearance for surgery, and this was her. She finally came to the doctor. She was a middle-aged woman. Her eyes were already yellow. She looked 9 months pregnant. She had
Oh my,
swelling from her thighs all the way down. And when I saw her, without even looking, I was like, this is cancer. And she had been having symptoms for months. Like I just was so heartbroken because I know within myself that if this woman had gone and got herself checked out, these cancers are treatable.
they're treatable, yes.
They're
And that's
treat.
a sad thing. That was
Uh,
making me very sad. Like cervical
yeah,
cancer, I'm seeing so many. For some reason, we had a high influx of young cervical cancer patients, and they're so far advanced. Especially if you're getting chemotherapy for it, it's sad, and they're probably not going to live long because of something as simple as going to get. And that's the one thing you can get screened for is you can get a pap smear each year, and
right,
they have, like I said, this resource around there. Getting a pap smear is probably the easier thing of, other screenings, but it just makes me sad because it could have been avoided just a simple test or just saying, hey, I'm
right.
just going to my primary care doctor. But
Hmm. Yeah, just to go through some facts. These are facts. Cervical cancer occurs most often in women over 30. So that's an early age of presentation. Um, just so you know, the cervix is the lower or the narrow end of the uterus. The cervix connects the vagina, which is the birth canal, to the upper part of the uterus. Cervical cancer is the easiest gynecological cancer to prevent. And that could be, just like Kenya said, with your regular pap smear. And also, when you do a pap smear, you do the HPV virus. So HPV is the human papillomavirus. It's the main cause of cervical cancer. HPV is a common virus that's passed from one person to another during sex. Early on in cervical cancer, you may or you may not have symptoms. So that's exactly what Kenya was saying before. It's not really until it's advanced that you may have bleeding or abnormal discharge. And it's two
yeah,
simple screening, HPV test and the pap test. And that's why I'm from an era where and I'm sure with you, they're now giving boys and girls the HPV
same.
vaccination. So, I mean, if they get vaccinated, that prevents that virus that's going to cause cervical cancer in women. So this is important. Both males and females can get it, but that has to be done. I think for boys and girls age 11 to 12,
Like,
it should be
yeah,
given as early as 9 and can only be given up until age 26. And the vaccine is given in a series of either 2 or 3 shots, depending on what age you started. So that's totally preventable and treatable. You can get tested for that one. So that we're doing this so we can encourage people to take better women, and now males can get on it because they can get their children. The young men can get the vaccine to prevent cervical cancer. You agree?
yes, they can.
Yeah. And also just so we understand the difference between uterine cancer and ovarian cancer, all women are at risk for uterine cancer. That's for
Yes.
sure. And that's when we talk about the symptoms of discharge that's not normal to you. Heavy bleeding, bleeding that's after you've gone through menopause. Any bleeding after a woman has had menopause is abnormal and should get you sprinting to the doctor. Do you agree with that?
And yet you still have women that put it off as like, oh, maybe this, and I actually, and my mom she didn't necessarily come right away. I just so happened called her and she was on her way to the doctor and I asked her why. And she had bleeding. It's just she said, well, I just had this one time where I had this bleeding and it ended up being a polyp, which is why you have this bleeding and it stopped. But any bleeding, any spotting, especially, postmenopausal it's not normal.
It's not
And you
normal.
need to get a biopsy, yes. Because there's usually no pain. If you're having pain, it's way too late. If you're not having pain, if you're starting to have bloating, all these things, if you're having these symptoms, it's probably late. But bleeding is usually, especially postmenopausal bleeding, is the first indication. And it's still people that ignore that one symptom. It's like, well, it only bled once, because I think my mom would have been one of those people
Mm-hmm.
if I hadn't just. She tells me stuff, but she'll tell me stuff a little later. But I just so happened I was calling and she was going to the doctor's office. I was like, oh no, we about to get you seen by oncologists like now so they can do a biopsy to make sure.
Right. Thank God she had you.
Yeah.
Um, Another thing is, so with ovarian cancer, so just so we know, all women, we have two ovaries. They're located in our pelvis. Um, and our chances of getting ovarian cancer increases again with middle age and older. If you have close family members that have had ovarian cancer, or if you've had breast or
Breast cancer,
uterine,
right?
right, or any colorectal cancer. And actually, ovarian cancer is known to have a higher risk in the Jewish people with a Jewish background, or if you've never given birth to a child or had problems getting pregnant,
Right.
or also with if you have endometriosis, which is really a condition where tissue from the lining of your uterus grows outside elsewhere in your body. And it's the same thing again. Ovarian cancer, you can have that vaginal bleeding, especially postmenopause. You have pain or pressure in the pelvic area or your abdomen, back pain. I know Kenya mentioned bloating several times already.
That's been bloating has been it's usually hardly any pain. What brings people in is like, I finally got this check because I'm so bloated. I thought I was just gaining weight. I'm just bloated. I'm not in any pain. I'm not anything else. I'm not bleeding. It's bloating, and I know it's and that's why it gets missed, and that's why usually by the time we diagnose this is stage 3 and 4 because it was something. I mean, I can eat a hamburger and get bloated, so it's just something that people can easily ignore. But that has been
Right.
the thing that's like, well, I noticed I was having bloating. Most of my patients that I've spoken to that's got diagnosed with ovarian cancer, I always want to know what finally brought you in. Like, what was it that you knew was abnormal? And it was,
Hmm. And
so
also just
I mean, it's continuous bloating. It's not, I ate a big meal and I got bloated. The next day I'm fine.
right. But if the
Thinking women
bloating goes away after you've gone to the bathroom, we're talking about just
bloating
your
for nothing you're doing.
continuous. Yes. Yes.
You do is fixing it's bloating, it's getting worse. I'm eating, I'm passing, all these things are everything else is fine. It's just this continuous bloating, sensation. So
Yeah. Another thing too, to just since we're on this topic, you can have vaginal and vulvar cancers,
mhm.
which you should be looking, that's why you go in and get checked too. Somebody else is looking to see if they see any abnormal lesions. Women can have cancer, just from if you're not checking yourself at least you're getting an annual checkup and your pap smear so we can and when you do a pap, they check for HPV. So a
Yes.
pap takes care of a lot of things. And just them doing the exam, you can see if you're having any abnormal pain or discomforts, which you really should not be having.
Right. Or some of the things that you may think is normal, like, oh, I've always had this, doesn't mean that it's
Normal.
normal. It's just a normal for you because you've been having it, but it doesn't mean that's a normal thing to have. So it's good to have or speak with someone. I always too recommend, even for my daughter, because I know on her father's side, her paternal grandmother had breast cancer and all those things. So it's so early, and so genetic testing. I don't feel like we utilize that tool because at least the one tool that you can try to predict if you might have this. If you have this gene, am I higher risk for breast cancer? Am I higher risk for ovarian cancer? We need to be using genetic testing.
Yeah.
Is out there. All these things has advanced, and it's pretty. And most insurances, they want to, of course, they want to know if you're at high risk for something. But I just feel like if we even utilizing that, knowing your family history, how sometimes you're like,
Yes.
what did my aunt die of, or what is this? I mean, knowing your family history to know whether you need to even go do these things in the first place, or knowing that you should be getting more screenings. If you know people have gotten diagnosed with cancer or breast cancer or cervical cancer in their 40s and their 50s, you are probably want to be one that screens more often or
Right.
go get genetic testing. So genetic testing, my eyes have been open in the last 3 or 4 years. I was like, I feel like it just should be part of a regular physical now.
Right.
That's helpful it's been to see what they're going to be at risk for and treatments and everything. So,
I'm so glad you brought that. That's an excellent point. I know that I was even talking to a fellow coworker about that 23andMe because
uh-huh.
I'm gonna pay and get that done on myself because you are absolutely right, especially in the African American community. We do not talk about our family history of illnesses. When you go to your doctor or any medical provider and they're asking you about the history, that's an important thing. We're
Yes,
not just asking to be nosy. We're
right.
asking, we are asking so that we know what cancers you may potentially have a higher risk for. And it's not just cancer. That's the same
Heart
reason we
disease,
ask
it's
exactly
all the things. Yeah.
who had heart disease, who had Alzheimer's,
How
who
old were
had
they?
exactly, who had a stroke, who had a heart attack, who has diabetes, because you can't necessarily get away from your genes. And we need to take advantage of these simple testing. Who's getting their colonoscopy?
Right.
I mean, come on, we got to do better. That's why we're here. I'm passionate about it, and I know Kenya's passionate about it because we hate to see how, we know people could have done better. They didn't have to go through what they're going through or even die as young as they're dying if there was the early detection, if someone knew their family history and was serious about it. You cannot continue to blame the healthcare providers. You have to be your advocate. You have to take charge of your health and say, hey, I know my mom and them had X, Y, and Z, so I want to be checked for this.
Right. And
You
we
have
have
to
people
do
like
it.
that. Yeah, you have to be almost annoying. You have to be aggressive. I mean, because this is your health, because you're the one going to, have these things, or you're the one that's going to debilitate, or, this is your body, your life. You have to be more proactive in your care. You can't assume that, doctors are swamped. We can have less and less family practice doctors, and we have to make sure that we are getting what we're supposed to get when we get there. You need to be knowledgeable, is so the doctor needs to be knowledgeable so you guys can work together. But some things you have to push for, you have to ask for.
Yes. You have to be your own advocate and your family's advocate. You really do. This was so good, Kenya. Thank you so much. Do you have anything else that you want to share with our audience?
No, I mean, just making sure that you are paying attention to your own body and everything is important, and you rather be, overreactive than, underreactive to, listening to the signs of your body. If you're bleeding, if you're bloating, just go get checked. It's worth every penny to catch any of this early. It's worth your whole life. But, I just, I will hope I have to find, we'll have to come back again and come up with some more resources, because I didn't even think about that beforehand. It's a lot of free resources out here. If you don't have insurance, if you worry about costs, because your life is priceless. So screenings and, just going to do regular checkups is very important.
Oh, no problem with the getting the information out. All you have to do is just get those resources out to me, and it will be in my notes for this episode. And even the notes that I have today, I'm going to upload those into. You just have to look under the notes for this episode, and you'll have all of that. And I just want to mention two more things too that we did not mention: smoking and obesity.
And obesity. Yeah. And that's
Those
one of the biggest
things,
things in
yes.
uterine cancer, that can keeping your weight down and under, at a healthy, I know people like, they love their big and beautiful body. That's great. But, and that's what we mean when we like, it's not healthy in general. Just having that extra adipose tissue, that extra fat tissue feeds cancer. That's the most of the women. So that's another, it's just a risk factor that we have control of. You don't have control of your
Yes.
genetics. You don't have control of a lot of things, but you have control over that. And anything that you can do to lower your risk, obviously stop smoking, losing weight, or staying in a healthy, weight range, all those things will be extremely helpful.
Okay. All right. Well, thank you, Kenya. And I look forward to having you back on the Health Flow podcast. And we'll get those resources out to everybody.
All right. Thank you.
You're welcome. Are you thinking about starting your own podcast? If so, Anchor is the easiest way to make a podcast. Let me explain. Number one, Anchor is free. Anchor has all the creation tools that allow you to record your podcast and edit it right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, Google Podcasts, and many more. You can make money from your podcast with no minimum listenership. Anchor is everything you need to make a podcast in one place. Download the free Anchor app or go to anchor.fm to get started. Thank you for listening to the Health Flow podcast. I hope you found this session informative. Email topics of interest or questions to the Health Flow podcast at gmail.com. Follow me on IG at the Health Flow podcast. Like us on Facebook at the Health Flow. You can also leave a voice message. Hit the subscribe button and give us a 5-star rating. Until next time, have healthy thoughts and do healthy things.